Yes, we are starting now. Good evening and welcome to this international webinar at Believers Church Medical College and Hospital. This is our 62nd international webinar and our 5th best talk. And to speak on this webinar, we have none other than one of our luminaries in cardiology, Dr. Chris Vijay, MD, who is the director of the Institute of Cardiology, Institute of Congestive Heart Failure at Abrazo, Arizona Heart Hospital and Abrazo Health Network in Arizona. He's a non-invasive cardiologist, a trained endocrinologist, clinical lipidologist, an ardent researcher, and a heart failure specialist. Dr. Vijay has practiced in India, UK, and has been in medical practice in the US for more than 35 years. He's a clinical professor of medicine at University of Arizona, past governor of the American College of Cardiology, Arizona chapter, immediate past executive council chair of National Lipid Association, a founding member and past president of the Renal Society of America. And he is currently the president of Twin Epidemic, a non-profit organization addressing diabetes and heart disease among underserved communities all over the world. Dr. Vijay is a recipient of numerous awards, including an Innovation Award through the Center of Health Innovation and Clinical Trials at the Arizona State University. Arizona State University.
No, rest please.
And
Go lunch.
please mute your audios, dear friends.
There limit. Go do it.
Please mute your audio. Dr. Vijay has participated in more than 180 clinical trials and has research is focused on such disorders as congestive heart failure, hypercholesterolemia, hypertension, coronary artery disease, plaque regression, atrial fibrillation, peripheral vascular disease, and diabetes metabolic syndrome. He has published numerous articles in peer-reviewed journals. Dr. Vijay serves as a clinical professor of medicine at University of Arizona, Phoenix, and as an adjunct professor of medicine at Midwestern University, Arizona College of Osteopathic Medicine, ASCOM. Dr. Vijay takes a holistic view of heart disease prevention and treatment, using a variety of treatment options along with motivating, inspiring, and coaching to encourage patients to modify their lifestyles. His mission has been in prevention of risk factors of heart disease and diabetes at primordial, primary, secondary, and tertiary care levels. He is the author of the recently launched book, Invoking Your Inner Therapist in Heart Failure, Untold Patient Experiences from Prevention to End Stage. He has also been a frontline worker at Arizona Heart Institute and Hospital during the COVID-19 pandemic. He is, very interestingly, a medical Sherpa, volunteering his services to serve the underserved in attempts to mitigate diabetes, heart disease, and kidney disease around the world through his non-profit organization, Twin Epidemic, Inc. He's also a needs ambassador for a large multinational non-profit organization, Project Cure, providing services for the Dalai Lama Heart Foundation in Ladakh, India, in the Himalayas. Sir, it's a great privilege to have you in our midst. We are really, really honored since you've spared the time to come and talk to us. Welcome, sir. Welcome to our international webinar. And to moderate this session, we have one of our great stalwarts, Head of Pediatric Cardiology, Dr. Suresh Kumar, sir. Sir is a great treasure at our institution, and he was a postgraduate teacher in cardiology in medical colleges of Kerala from 1983 to 91, served as consultant of the first comprehensive pediatric cardiac service in UAE at the Maraf Hospital, Abu Dhabi, till 2004, and then worked as head of pediatric cardiology at the M Foundation Frontier Lifeline, Chennai, up to 2014. He was an international scholar in pediatric cardiology, Cleveland Clinic, in 1997. He served as senior consultant in pediatric cardiology at the National Heart Center, Royal Hospital, Muscat, up to 2017, and piloted the humanitarian drive, Hridaya Purvam Sakhayam, a joint initiative of the Madras Medical Mission and Malayalam Manorama in which 400 underprivileged children with heart disease were operated free of cost. He's the author of over 30 publications and several textbook chapters and e-teacher for pediatric cardiology residents. He was an invited speaker at UCSF Cardiology Grand Rounds and an invited faculty for CSI, Dubai, Frankfurt, and UCSF. He was also the course director at Advanced Cardiovascular Therapeutics, the Madras Medical Mission, Chennai, from 2006 to 12 and in 2019. Suresh sir, thank you so much. Amidst your busy schedule, you're here with us to moderate this session, and we are here waiting to hear from two doyens. So welcome, Suresh sir.
Thank you, Jacob. It's just my duty to invite Dr. Chris Vijay to deliver his lecture, to which we are looking forward eagerly. An intriguing topic by an excellent speaker. Dr. Chris Vijay.
Thank you very much, Dr. Suresh and Dr. Jacob. I'm truly humbled and truly honored to be here. It's such a joy to be of some service in terms of education. And I think we're in this space where we're truly educating a lot of people. And every day, as I go about waking up from bed and trying to decide on what my next steps are, two things come to mind. One, I'm either teaching or I'm learning. And those are the only two things that happens throughout the day. And I'm having so much fun just doing that, regardless of what goes around you, right? And see what's going on around you today and in the last month. Truly, the COVID-19 landscape is changing every day. The events of the past months has been really a stark reminder of the crucial role the public health is playing in our world. It's been a challenging time for the society across the world with major disruptions across virtually every sector. And truly, in spite of these disruptions, I believe that there is a shining light. Dr. Suresh just mentioned this morning, before we all got together at this meeting, he mentioned that, yes, this will go away, even this will pass, and then we'll still go about doing the things that we need to do. And truly, during this time, we're all learning some of the most powerful values that are sustained over time. And those values are about love and about kindness, about compassion and about service to others, about innovation and about creativity, about inclusion and impact. Yes, we can always argue that, there is an endless exhaustion of endless learning and fatigue and the uncertainty of it all. And yet, I strongly believe that each one of us is still having a certain unquenchable thirst for a different life, to have something that will move away from us with all the negatives and then move on with the positives that will be coming forth, not today, not tomorrow, but maybe within a week, within a month, within the next few months. And I strongly believe that through collaborative effort, our community will brave the challenges and solve the growing problems through the power of education, through the power of knowledge, and through the power of passion. To that end, I believe that what you're doing from Believers is phenomenal. And I'm so thankful for the opportunity that is given to me to really cut through some of the ice, debunk some of the myths, talk about some of the prevention strategies that we can do, be it in non-communicable disease, and now with the communicable disease that is affecting many folks who already have a risk factor for non-communicable disease. Share the knowledge with you all in pursuit of a healthier, more equitable world. Let us now reassess all of this discussion that we are talking about, and I'll be sharing the screen in a minute with you while I upload my slides and start the conversation here. I believe that this is my slide kit, and let me see if I can come up with, okay, so. Can you see my slides yet, or I need to share the screen, right?
Yes, sir.
So let me see. You have to allow me to share the screen. Where am I here? Okay, share screen. And does it come through? Can you see it?
Yeah, it's fine. You can
It's
go
fine?
ahead. Yeah,
Okay,
it comes through
fantastic.
very well.
Okay, great. All right. Uh, uh, so this is it, right? So as I mentioned, we're going to be talking about this intersection of the cardiorenal metabolic, the risk factors that leads to a cardiac disease, leads to heart disease, kidney disease, or even diabetes. Can we prevent many of this? And can we do it through empowerment, both at the patient level and at the healthcare provider level, at an individual level, and can we also do it at a population level? So my outline is going to be about the interconnected nature of all of these three disease states. They're not living in a silo. They're all connected very deeply. And we'll share the risk factors that contribute to the development and progression of these conditions. And we're going to talk about the impact and highlight how can we collaborate our management strategies by first do no harm approach, and then how can we proactively intervene. So what are some of the risk factors then? You already know many of this: smoking, blood pressure, cholesterol, the LDL, which seems to be genetically mediated more than 90% of the time with more than 1,700 genetic mutations, whereas triglyceride may be related to the environment and to the diet partially. But you also have the other risk factors such as obesity, such as physical inactivity, which is very important that we should talk again and again from an Indian phenotype, and family history, and what are the psychosocial factors that may actually impact some of the negatives that may go on with a plaque rupture that happens suddenly because of a psychosocial emotional rage or anger or a sudden disruption of that plaque that happens suddenly in spite of having had a negative stress test, so to speak, a week or a month ago, and yet suddenly somebody is having an event. How do you explain that? We're going to talk about some of these things, and we'll take it from there. So this slide is very visual, very busy, but it's again telling us briefly, starting off from the bottom here, where it talks about the risk factors. If you get diabetes, blood pressure, obesity, or dyslipidemia, we are now talking about in the blue semicircle, we talk about spilling of albumin in the urine because the inner lining called endothelium gets dysfunctional. And from there on, the kidney starts to become worse. There is a macroalbuminuria, more than a gram of protein in the urine, and slowly becomes a renal disease. So that's one component in the blue. But simultaneously, in the red, as you see, the same risk factors are contributing to a left ventricle that becomes a little bit thicker because of high blood pressure. Then there is coronary artery disease with plaque development. We'll show that plaque development and genesis of the plaque in a minute, and causes the plaque rupture, which causes the clotting factors to come like a volcanic rush into the cavity of the blood vessel, causing that blocked artery and a heart attack, and then or a stroke, and then causing to all kinds of arrhythmia problems, remodeling of the left ventricle, heart failure, and death. So if you start off with these risk factors and they're contributing to the cardiometabolic renal intersection, then we ought to be asking the question, what is the common link for all of this? And if you look at this next slide, you'll realize the common link may well be the inner lining of the blood vessel, which is called the endothelium glycocalyx intersection. And what is that? But that is the lining that now traverses throughout the body from head to the toe. And if you put them all together, there's so many millions and millions of cells. If you put them all together, you realize that this can go around the circumference of the earth about 4 times. That's how big this organ is. And each of these cells are performing a very phenomenal action, which is actually protecting you. It's a defense mechanism. There are 5-fold functions, right? So one, it actually between the two cells, it prevents the plaque from going underneath, or the LDL and the oxidized LDL to slowly start developing outside the cavity of the blood vessel first, and then encroaching into the cavity later down the road. But that is the permeability barrier that the endothelium is protecting. Number two, it balances vasoconstriction, vasodilatation. Angiotensin is a vasoconstrictor released by the endothelium. The nitric oxide is released by the endothelium, which is the vasodilator. Beautiful balance. It balances the clotting and the bleeding. The clotting is the PI1, the plasminogen activator, produced by the endothelium. Bleeding. And the bleeding factor is the TPA, or the which is the clot buster that we use, and that is also produced by the endothelium. It's a beautiful balance, and it also acts as a transducer of the biomechanical forces and protects that plaque from developing at the branch vessels. And then in number 5, it creates all these chemokines and cytokines. You heard about the cytokine storm that happens in COVID-19, causing clotting. And that is again from the endothelial disruption, and it becomes disrupted because of high blood pressure, because of high blood sugar, because of lack of activity, because of lipemia, high cholesterol, because of obesity, because of inflammatory milieu with fibrinogen, CRP, PI1. If we look at all of this, this is one most important slide which explains why the disease states happen and why we ought to be focusing on stabilization of the endothelial glycocalyx intersection inside every blood vessel, so as to prevent onset of diabetes, onset of blood pressure, onset primordial, or onset of disease after you have any of these risk factors, called primary prevention. And then after you have these risk factors, then getting into heart attack or stroke is secondary prevention. And then once they have that and slippery slope and heart failure requiring heart transplant, or LVADs and assist devices, and now suddenly they don't want any of that. They want to be at peace with themselves, and that's tertiary prevention. So yes, so let's start off with the plaque. So the plaque is developing, as you see, because of the blood inside the blood vessel, and this is outside the blood vessel, but the endothelium is right there, which is now allowing the LDL to go in, the ApoB to go in, and the LDL gets oxidized and modified, and the macrophage, the monocyte goes in, becomes macrophage, LDL gets engulfed by the macrophage, and it becomes a foam cell. The foam cell is a very powerful inflammatory organ and a molecule that is now creating all the inflammation in the level of the endothelium, leading to that plaque and the plaque rupture. And the plaque rupture is the one that causes the problem. And what's interesting with this slide is that by the time, as you see, the plaque is developing, by the time the cavity starts to narrow, the plaque is already occupied more than 75% of the circumference of the blood vessel. Only then it starts to narrow. So when you do an angiogram with a dye, you're only doing what is called a luminogram. You're not really looking at the blood vessel outside the cavity. There, the plaque is already developed. And some plaque that you see in the cavity may be just the tip of the iceberg. That's the message from this slide. So what are some of the other risk factors that actually get really upregulated? As you see, a busy slide, but the bottom line here at the bottom is that it is vasoconstriction, thrombosis, inflammation, rupture. All of this is because of all of this biochemical mechanistic basis that happens on a continuum with the addition molecule and the PI1 level and proteolysis and inflammation, all triggering some of this basis for that plaque, the buildup and the plaque rupture. The next 3 slides are going to talk about one component of the 3, such as the cardiac dysfunction, how it is intersecting with the other 2, the metabolic and the renal. So when you talk about cardiac, it starts off with hypoperfusion, lack of blood flow, and the activation of neurohormones that happens the minute there is a damage to the heart muscle through high blood pressure or through a blocked artery or through a viral attack on the heart muscle like COVID does for myocarditis. And then the neurohormones are now activated, which to a certain point, it's a good thing. It's a defense mechanism. But after a certain level, you suddenly starts to hurt the heart. It's like, eating 2 idlis is a good thing. And then you eat 10 idlis, that's going to backfire and hurt you. But that's exactly what the neurohormone is. And then the volume overload happens after that. And all of this is now leading on one hand to insulin resistance and increase in free fatty acid, and which is the metabolic component. And on the other hand is declining kidney function because of hypertension and diabetes. And now if you start with kidney, and then how does that translate to the other two conditions? You'll see that the glomerular dysfunction or the renin-angiotensin activation, sodium retention, oxidative stress are contributing on one hand here to a cardiac remodeling. And then on the other hand, again, to insulin resistance and all the components beyond. We start off with the diabetes and the metabolic components and energy metabolism perturbation. You'll see that it is now translating to altered kidney function through albuminuria, low GFR, and also building up of the plaque. And even without building up of the plaque, there is heart failure ensues because of relaxation issue in a diabetic patient. About 2/3 will actually have relaxation problems and not have any significant plaque burden. So these three are important because when you put them together and they seem to intersect, one component of this disease goes to another, suddenly we are on a slippery slope and the life is not good. Quality goes down, and we also see mortality increasing significantly. So you see 50% of patients with type 2 diabetes have or at a higher risk of developing heart disease. 33% have CKD, but CKD affects up to 40% of patients with type 2 diabetes. So chronic kidney disease. So we're talking about, this slide is about again, your histogram, where it talks about the mortality per 100 patient years if they have no diabetes, no heart disease, no kidney disease. Here it's 6.8 per 1,000 person years, right? But when you add diabetes, it now not only doubles, it goes beyond. When you had diabetes and MI, it's 32. And when you add diabetes, stroke, and a heart attack, now it's tenfold. So just a little message here that, from 0, suddenly it is tenfold risk of mortality. And when you look at this slide, it is just what is highlighting here is the number of years lost. So we're talking about mortality with this 3 component of this disease, 1, 2, or 3, we have suddenly lost 15 years of our life. If one were to die at age 75, for example, and suddenly they die at age 60, you have lost that 15 years of very productive, not only life, but also mingling with family, friends, grandchildren, enjoying the beauty of life around you, and you missed out. And the children and the grandchildren have missed out on the wisdom and the mentorship that one is supposed to be imparting to the next generation and hand-me-downs. And all of that should be taken into account. And when you see the next slide, you see that the heart failure and diabetes are very intertwined, and the hazard ratio more than 1 is not good. 1.4 for people even with normal heart pump or ejection fraction. And then with the reduced ejection fraction, it's even higher. The hazard ratio is 1.73, that much impact on mortality. And when you look at kidney, the 2 things that crop up, one is what is called GFR, and the GFR goes down, the graph, the trajectory is going up, and that is about cardiovascular mortality. Nobody dies of kidney disease. The minute they have kidney disease, they are now having cardiac problems and they die of heart disease. So then why even bother about, you can always dialyze the kidney disease patient, but then the heart disease ensues and that's how they die. So why not prevent kidney disease from occurring? The other slide is about the albuminuria, and the albuminuria goes beyond the threshold point. Mortality is significantly rising. So in a sense, it's a multifactorial management, right? You're talking about screening and glucose control. Your A1C should be less than 7. Blood pressure, keep it below 140/90. LDL for Indians, now the Lipid Association of India has come up with less than 50, less than 70 for all Indians, and less than 50 if you have a 2 risk factors. and even closer to 30 if we have events with heart attack and stroke, and lower the better. And we know the data is there for LDL. We don't have enough data for all of the other components of cholesterol. But again, diet and exercise and lifestyle are so critical. And if you look at what happened in diabetes, we have learned over the years that many of the medications that we have used did not really make an impact on heart disease. The UKPDS, the Accord, advanced aggressive management of A1C did not translate to a cardiovascular disease. If anything, there was in the red, you see there was a suggestion of an increased mortality or stroke with aggressive A1C reduction. Maybe because of hypoglycemia, we're not sure what happened there, but it's not very clear. But regardless, what the FDA said in 2008, that every diabetic medication has to go through the rigor of a clinical trial that will look at the safety of cardiovascular, because they found rosiglitazone had a problem in meta-analysis, increasing cardiovascular events and mortality. So that's when they decided, well, is it true or is it not true? We're not sure, but why don't we just go about doing safety studies? So they started the SGLT2 receptor antagonist and also the GLP-1 receptor agonist. And they looked at empagliflozin, canagliflozin, dapagliflozin, and they found significant benefit. Not only the safety was established, but beyond that, it is looking like it is making an impact on cardiovascular mortality, and it is making an impact, as you see in this forest plot, the cardiovascular death, which is left of the midline. And it is also impacting in canagliflozin, impacting all of the major adverse cardiovascular events, non-fatal MI, non-fatal stroke, and cardiovascular mortality. If you look at the kidney, right, the last here bar graph here at the bottom is kidney disease, 40% reduction in worsening of kidney disease. That means it is improving kidney function and preventing the progression of kidney disease. And it's approved for that indication now in the United States. So we have a lot of this data now, which is essentially showing that the SGLT2 receptor are a good agents in patients with diabetes and established cardiovascular disease, and even with risk factors of cardiovascular disease. What about GLP-1 receptor agonists, liraglutide, semaglutide, dulaglutide? All of them are now approved if they have established cardiovascular disease. The dulaglutide they approved recently even in patients with risk factors for cardiovascular, such as diabetes and one other like hypertension. And they're saying to prevent the first event from occurring, now it is indicated. It's an injectable once a week, but it is making a huge impact. And that needle is not even, you don't even feel it. And why not start looking at agents that have a favorable impact on heart disease and kidney disease? So we look at that transition of the heart and kidney disease to the risk factors, that is doing a dance macabre, or as you see over here, a complex conundrum from the basic risk factors all the way to heart failure and death. And we have to believe that we have to treat heart failure aggressively before it gets worse, and through symptom reduction, hemodynamic abnormality, and survival, improving agents such as beta blockers, ACE inhibitors, angiotensin receptor blocker, agent called sacubitril, valsartan called Entresto in the US, and spironolactone, and sodium restriction, and use of diuretics to get the volume out, but not for mortality reduction, but make them feel better. And then we have the defibrillator biventricular pacemaker that's also showing benefit in mortality reduction. And an agent called ivabradine is doing something amazing in preventing recurrent hospitalization. Through education, disease management, performance improvement. In kidney disease, we have seen the next few slides, I'll go quickly for lack of time here, that there is a benefit not only of SGLT2, but also pentoxifylline, the bar graph going down, and with the use of bicarbonate if they have acidosis, and with the use of allopurinol if they have hyperuricemia. And with all of these agents that we have now in this space, we are talking about utilizing SGLT2, GLP-1, and metformin primarily before we start using all of the other agents because we know now that diabetes, heart disease, and kidney disease are very powerful. And this slide essentially is about the comorbid condition. Nobody lives in a silo. You know, we can take Dr. Jacob, Dr. Suresh, each one of them are amazing doctors, but beyond, they're also amazing human beings with caring, compassion, and they're probably great chefs, and they probably play fantastic tennis or basketball. They do this and that. So what is that about? So each one of you in the audience is not just a healthcare professional. You are beyond. You bring out and embody that humanism in every inch of the way. So why am I saying that? Because disease state also exists and coexist together, not just in one silo, in one box, in one compartment. So when you add one other to a type 2 diabetes, then your treatment strategy should be geared towards that. And I'll be happy to share the slides later with Dr. Jacob and Dr. Suresh, so you can actually look at it a little bit more in detail. So what is it we are talking about beyond all of these medications and therapies and lifestyle modification? We ought to be looking at something even beyond, and that is the value-driven approach. We need to be looking at the people and the players in this space, and what kind of partnership and collaboration, what is the process, how do we position, what are some of the positivity and power to empower. So be nice. You know, Sarah Bernard says, be constructive, be tolerant, and life engenders life. Energy creates energy. It is by spending on self that one becomes rich. And when Harold Janine said, I don't believe in just ordering people to do things, you just have to sort of grab an oar and row with them, do it by yourself, and provide an inspirational, transformational message to your patients, to the people around you, filled with credibility, filled with empathy, and attack the 4 A's. Give them access to care, make technology available, make it affordable. If it's not affordable, then it is not even available. Then what is the point? And the acceptability in terms of cultural nuance, because some of them will have Ayurveda, homeopathy in mind. Yeah, all of them may add benefit and value beyond allopathic, be inclusive. And then, as you know, that it's not just one person who's going to do it. It is like Mother Teresa said, none of us, including me, ever do great things, but we all can do small things with great love. Collaboration and teamwork together, we can do something even more wonderful. And yes, the humanness has to be brought out. The ability to see that in every individual, to personally connect one-on-one, to chip in, to participate, to be content, to be themselves, and to uniquely tip the balance of life towards the warmth of togetherness. I understand in COVID that warmth of togetherness is lacking in a big way, but let's make sure that we get to that space by doing all the public health measures and anti-contagion measures, and making sure that we don't mingle unnecessarily if we don't have to. And then be that person. As in Bhagavad Gita, it says when a people person enters the room, it feels better, it feels safer, it feels happier. There's nothing like failure. It's only temporary defeat. It's nature's way of strengthening each one of us to give that courage necessary to reach your goal. Only one's rival's own potential is your rival. Not living up to your possibilities is defeat, although it still should be temporary, is what Bob Proctor said. And what Gurcharan Das, our own person from University of Chicago, is talking about this. When a child is asking, what is my purpose? He says, well, your presence in this universe is a metaphysical concept about the unity of that individual and the universe. And how do you do that unity? It has to be through self-development with all the values we're talking about as the core objective. And sure, charity is the universal code. Illuminate the dilemma that we are doing today, right now. And look at the moral and societal reflection, but be grounded in knowledge, be grounded in passion, be grounded in compassion, and combine it with the scholarly, the need-based, the meditative, the personal, and articulate with the contemporary taglines and what is the need of today, and embody that through the humanism concept. While the world is changing, we know that we need an enduring appeal. We need goodwill, we need charity, we need love. We need to shine vividly. And the message of all pervading love is what is going to be standing very tall. An unwavering faith, a message to wonder and worship, and a message of hope and message of harmony through primary prevention, secondary prevention, tertiary prevention, and no harm, because many of these agents have been showing to do harm. Many of the agents that we know can cause significant side effects with myalgia, with kidney problem, with conduction disease, with inflammation, all kinds of things. Be cautious about using a chemical agent and know the side effects before you use it. And so in summary, there is a fundamental shift in the cardio-renal metabolic space, and the effect on the surrogate is no longer sufficient. We have to look at the silos, not just silos, but horizontal integration through comorbid condition. We have to look at the safety, and we have to look at the treatment that improve cardiovascular, not just improve the A1C, not just improve blood pressure, not just improve LDL cholesterol, but does that translate to a reduction of the bigger picture of cardiovascular, renal disease, and cancer, and death? That's the way we need to be addressing, by first doing no harm and treatment of strategies that have an efficacy endpoint. So join me to tell your patients and your colleagues and friends and family to join the 100 Club. And I say this: get the blood sugar less than 100, get the blood pressure systolic closer to 100, get the LDL less than 100, get triglyceride, they say 150, but closer to 100 is even better. Get 100 calorie consumption per hour of wake time. You're awake for about 16 hours, 1600 calories, more than enough. And exercise for 100 minutes a week. And so join the 100 Club, do anything and everything you can, build that muscle, because anti-aging is about anti-sarcopenia. The atrophy of the muscle happens as we age, and build it and keep strengthened through cardiovascular and through a little bit of weightlifting, any which way you can. And this is my alphabet soup. I talk about A, B, C, D, E, F, G, and then I added the H. And A is for aspirin, A is ARB, amiodarone, which whenever the indication is, think of the B as the beta blocker, blood sugar control, and metformin. Think of C as the cholesterol lowering, cessation of smoking, clopidogrel if they have a stent, and the CRT defibrillator if they have heart failure with low ejection fraction. And the ivabradine is called Corlanor in the US. D for diet, diuretic if the volume is high, digoxin if the heart rate is high, DPP4 if they need blood sugar control more beyond the SGLT2 or the GLP1, empagliflozin or any of the other ones, dapagliflozin, canagliflozin, they all in the A, B, C, D, E, they all are fitting right inside this. And F is fish oil, G is for genetics. We know that plays a part, but it's still less than 5%, 10%. And now you say the environment is playing a bigger role. Why don't we control the environment? Because we may not be able to do anything to the gene yet, but gene therapy is coming. There's a chapter in my book on gene therapy at the end. And I've talked about a lot of new things that's coming up. And then the GOD, right? So we got to be believing. You are the believers. You guys are doing something amazing by bringing the effect and the epiphany that we have to go through on a daily basis and influence the power from above. And if you don't, you go to H wherever that H is. So that's on a lighter vein. That's why I added the H over there. But this is the final last couple of slides. And I bring in Mother Teresa very close to me, my heart. And people are often unreasonable, she says, and self-centered. Forgive them anyway. If you're kind, people may accuse you of ulterior motives. Be kind anyway. If you're honest, people may cheat you. Be honest anyway. If you find happiness, people may be jealous. Be happy anyway. The good you do today may be forgotten tomorrow. Do good anyway. Give the world the best you have. It may never be enough. Give the best anyway. So I'm going to end with the sense of hope. After my presentation, we have a Q&A session. And that sense of hope is beautifully epitomized by the statement from Aldous Huxley. He says that the rung of a ladder was never meant to rest upon, but only to hold a man's foot long enough to enable him to put the other somewhat higher, thereby suggesting that yes, while we struggle with the disease that's going on today with COVID and the impact on multiple different organ systems in the body, while we are going through so many risk factors that translating to disease, and these disease translating to a significant reduction in quality of life and increasing mortality, we still have to believe with a sense of hope and dream that we will totally eradicate some of these risk factors and the disease rate if only we can put ourselves collaboratively with teamwork and with passion and energy and beyond. Thank you for your attention.
Thank you, Dr. Chris. That was a wonderful exposition of preventive cardiology, its link to renal disease, our current understanding of metabolism as its link to cardiology and renal disease, and integrating that in a world vision and a personal vision of philosophy. That was an excellent treat. Personally, and on behalf of believers, we are indebted to you. While I would request the participants to chat and raise questions, let me put a question to you. You referred to the choice of drugs in pre-diabetics and in diabetics without any complication. Have we reached a stage of understanding in metabolism where you have a preference that if somebody has, let's say, an HbA1c of 6.6 and he's otherwise fine diabetic, this is the medicine that I would give to them?
Absolutely. So let's go back to the data. So the question is there a preference for pre-diabetic state that will actually mitigate not only the A1C, reduce it, but also prevent complications from occurring from diabetic microvascular disease, eye, kidney, and neuropathy, and macrovascular disease, cerebrovascular disease, cardiovascular, and peripheral with amputation. And so the bigger question is, can we do something early on and prevent the onset of disease? So the one that is shown time and again is being metformin. So the biguanide metformin has been shown to actually just do that. And though it takes a little bit longer time in clinical trials that we have seen, metformin is still the #1 drug to go to, while because of the insulin resistance, it actually gets the peripheral utilization of sugar into the skeletal muscle, decreases the A1C in the blood, and also improves some of the other parameters, whereby we prevent the onset of complications. Now, the next question is, if with biguanide, with metformin, if you're not, and of course, lifestyle modification, exercise, and significant and weight reduction, all of that will help. Because we have, especially with the South Asians, we see the abdominal obesity and we see the waist to hip ratio with Salim Yusuf data suggesting that we need to be kind of reversing that trend. We're decreasing the abdominal fat and increasing the muscle bulk and muscle strength. If we did that, I think we may be reversing part of that diabetes and the complications of it all. They're studying SGLT2 in that space. We don't know yet whether that will fall in as a drug of choice, one of the gliflozin, the EMPA or the DAPA or the CANA. They're studying that and see whether we can use it at an earlier space and prevent the onset, because it works in that cardiometabolic renal space, that maybe we can prevent all of the complications that happen. We're not quite sure yet. I think time will tell, and that's being studied. And the SGL and the GLP-1 receptor agonist is also being studied in that space as well. Some of the other agents like the DPP-4 and your acarbose or precose, as we call it here, and all of the other agents so far have not really shown benefit if they're or in that pre-diabetic space. So the #1 answer again is metformin.
I haven't found a question yet, so I think I can afford to ask you one more. There is a lot of conflicting recommendations on cholesterol intake and statins that come from different American agencies. What is your take on this? I noticed that statins certainly occupied a pride of place in your alphabet soup.
Okay. So clearly, cholesterol is very complex, right? So we have a specialty in the U.S. called clinical lipidology, and I was blessed to have been one of the first 300 people who actually have the fellow of the National Lipid Association. And there is Lipid Association of India that is headed by Dr. Raman Puri and S.S. Iyengar in Bangalore, and they're all doing some amazing work. And also Venugopal from Kerala is all part of the same team. So we published 8 papers recently, all came in January of this year. from Lipid Association. I was blessed to be part of their authorship and by reviewing and commenting and making changes. What are we talking about? We're talking about LDL, which is the one that we know. And LDL, you have HDL, which is good cholesterol. Then we have triglyceride, which is 1/5 of that forms the VLDL, which is also a component of the bad cholesterol, the ugly cholesterol. So if you look at LDL, that is the one that is genetically mediated. And so the American Heart Association came and said, you know, you can eat whatever you want to eat. It's not going to change your cholesterol perspective. I don't think they did something right there. I think diet plays a significant role. May not be for LDL cholesterol, but for sure it drops the triglyceride when we don't indulge in high carbohydrate diet. Number two, also diet is important for blood pressure control and for diabetes control and for obesity, which are all intertwined again. So by saying you can eat whatever you want to eat because it's not going to make a change in your LDL cholesterol was actually doing harm, because you don't live in a silo, as I keep saying. The LDL doesn't live in a silo. Lipid is a dynamic concept. It's happening every microsecond with LDL, triglyceride, HDL constantly moving in out of the cell, in and out of the liver, along with sugar and all the neurohormones and cytokines that actually affect blood pressure and the inflammation. And they're all having a dance, they're dancing in glory inside every cell and inside the blood vessel. So you cannot just say that, you know, I can eat all I want, any amount of eggs and egg yolk that I can eat, and I won't have a problem with cholesterol is wrong, because truly they will impact the plaque building up if there is increased level of fat consumption, because it can increase the plaque genesis. Like the Atkins diet is no longer a diet anymore, because it produces all kinds of calcification inside the coronary arteries through the electron beam tomography or a calcium score testing. So there is something about vegetarian keto diet, but again, you don't want to be doing anything into the extreme. I think anything in moderation shouldn't hurt anybody, as Mark Twain said, but at the same time, be cautious based on your specific phenotype and the clinical risk factors, and then adjust it accordingly in terms of consumption. And moderate is good. And again, overdoing diet, because the American Heart came and said it's okay to eat whatever you want and it doesn't make an impact on cholesterol, I think they do something wrong. And we had so many editorials after that saying that no, that should not be the case. We still have to be, diet and exercise constitute, majority of our risk factors, and we can prevent it in the primordial state.
I'm very glad to hear you say that, because you rightly said, the American Heart Association recommendation did leave a lot of room for misinterpretation. And for people who wanted to go loose in any case, they could always swear by American Heart Association. And what you said is not only intuitively and biochemically correct, it is also supported by data over several decades. In fact, epidemiologic data with regard to primary prevention started accumulating from the 60s and 70s. It was related to community fat intake, national fat intake, national cholesterol and triglyceride level, and related to mortality data. So there is a long accumulated wisdom, knowledge, and experience, with some recommendations thrown away because of a few papers. I think you have put all collectively together and taken an integrative approach and given some solid recommendation. I think I have a question here. Adil asks, apart from diuretics, what are the other medications that can be practiced to cure CRS? Did you get?
Okay. Yes, interesting question. So diuretics, so CRS. So if you lose diuretics, that means you're looking at somebody who has fluid retention. So when they have fluid retention, then you use diuretics. When do they have fluid retention? Usually when they have heart failure. Is it because of heart pump is weak because of systolic, or the heart is not relaxing properly, which is, we call it as HFrEF, heart failure with reduced ejection fraction, or HFpEF, heart failure with preserved ejection fraction. So when you look at it from that angle, and they have fluid retention because suddenly the volumes are high, and the volume translates to oozing of the fluid out into the tissues, then you're retaining it, be it in the lung, be it in the abdomen, be it in the liver, be it in the legs, lower extremities with edema, as we call it. So we use diuretics to get the volume out. So when you have a problem, the root cause of the problem, which is, could it be heart? Could it be kidney? Could it be that it maybe the heart pump is strong, but it's not relaxing properly? Or is it because of some other condition that is causing problems with fluid retention? You need to be asking, is there a blockage like in the legs, like a deep vein thrombosis? Is there a blockage because they had prostate cancer and their prostate venous plexus has got some clots, which is not allowing the venous return back into the right side of the heart? Is that why they have edema of the leg? You need to be asking these questions both from an anatomical and physiological perspective. And when you do that, then two things come to mind. One, what is the hemodynamic status? And number two, what is the fluid status? If they have fluid, then yes, you want to use diuretics and to keep the volume out. But diuretics is not translated to a mortality reduction. It is not translated to a cure of a cardiorenal syndrome. It is only a band-aid by getting the water out of the body through the kidney and making sure the kidneys are not getting worse. When you do that, you still have to go deeper and dig deeper and get a little bit granular and ask the question, what is the root cause of the problem that caused the fluid to retain? If you give diuretics to essentially symptomatic relief, but not really addressing the root cause of the problems. You ask those questions and dig a little bit deeper and find out with some testing what is the reason for the fluid to retain. The second is hemodynamic. What is the blood pressure? Is it too high? Then you have to bring it down with other medicine. Is it too low? Then you have to watch and see whether the pump is weak. Is there something else that is causing the blood pressure to be too low? Those are the questions that you need to be asking. Diuretics, as in the clinical trial, is not translated to a cardiovascular mortality reduction, although it will prevent readmission to the hospital within 30 days is our mandate in the US, because if the hospitals don't get paid, if they keep coming back within 30 days to the hospital, nobody gets paid. So it's also a financial motivation to keep them out of the hospital. So all of that is ongoing, but that's the response that I have.
There's a question from Aravind Mutaya. Can you please explain about IFR and IRR and its role in stent placement? I'm not sure whether you would like to take that question.
You're talking about fractional flow reserve. So the fractional flow reserves are very important in the stent placement. So we know, as I showed you some slides in the beginning, that the plaque accumulates outside the blood vessel and slowly encroaches into the cavity. And so when the narrowing of the blood vessel is more than 70% of the circumference of the blood vessel, then you get significant ischemia in the physiological testing. If you do a stress test, you do a nuclear stress test, and you do demand supply equation, increase the demand and look at the supply. And if you see the supply is inadequate, then you know that the blood vessel may be more than 70% narrow. That's when you go in with an angiogram and then you look at it and see if it is blocked. If it is more than 70% that you can see visually, then you go ahead and put a stent in. If it's 90%, it may be very obvious. If it's a thin hairline, is all the trickle is going, it may be very obvious, and you put a stent in. When it is somewhere around 55, 60%, you're not quite sure, that's when your fractional flow reserve, it comes into play, and see the difference between the fractional reserve before and after the lesion. If it is less than 0.8, then you know that you may need to put a stent in. And if it is more than 0.8, closer to 1, that means there's not much of a difference between the two areas before and after the lesion, and you may not need a stent. And because the minute you put a stent, you're irritating that area, and they may come back with a vengeance and close it up. That's why you want to be careful and not putting stents in everything that you see, and you have to be very cautious of that. So that's where that role comes into play, I believe. And also now we do intravascular ultrasound called IVUS. And IVUS also will show whether the plaque is soft, or is it calcified, is it stable, or is it unstable. The morphology of the plaque can be determined through IVUS. You won't be able to determine through the fractional flow reserve, but IVUS will play a significant role as well.
There's another question. In an AKI patient, how can we prevent hypertension and diabetes? any methods for prevention?
So AKI stands for acute kidney
I believe acute kidney injury.
Acute kidney injury. And the question is whether can we prevent high blood pressure and diabetes in patients with AKI. But I think the question really is, can we prevent AKI in patients who have hypertension and diabetes? That should be the question, right? So I think I know what the audience, the person is asking. So in somebody who is hypertension and diabetes, if you control both blood pressure and diabetes and keep it on the lower end and make sure that they are well hydrated, as long as they don't have heart failure, I think you can certainly prevent kidney injury. Our body, 70% of the body is all water, fluids. So you need to be continuously, really making it flow like a river. Continuously, you got to be at the head to the toe. If you allow it to continuously flow like a river with increased fluids on a dynamic way, then you will be able to protect the kidney for sure.
I think we'll quickly go through two more questions because we are running out of time. What is the effect of change in diastolic and systolic pressure on GFR?
So that's a great question. So the GFR is the marker for kidney injury. So we call it eGFR, or glomerular filtration rate. So the effect, what is the effect of change in diastolic and systolic? So it's a very good question. We can talk about it for hours on end, but to just summarize, systolic is more important than diastolic in people who have above the age of, let's say, they say 45 or 55. Let's say 50 is about the above the age of 50, the systolic is a lot more important. Below the age of 50, the diastolic is important. But what is even more important is the difference between the two, and that is called pulse pressure. So the higher the systolic, lower the diastolic, that pulse pressure is higher, and that may actually start, worsening the kidney function. So yes, the systolic is important to bring it down, and the diastolic is important as well in younger people, but don't worry about it in the elderly, where the diastolic may be on the lower end, but bring the systolic down, and that way you can protect the kidney.
I think the last question would be, how can we manage CRS in COVID patients? And how can we prevent CRS in them?
Oh, fantastic question, right? So we are all struggling. Is there a medication? How can we, COVID is very powerful now and is really doing damage all over the world. And we don't have an agent that we can take right now. For me to take 4 capsules twice a day, for example, what is that? What is it that we can do to prevent me from getting to the hospital? The minute I go to land up in a hospital, my oxygen level is lower, then nobody can see me, and we don't even know what goes on. Everybody is under significant strain, and so the care suddenly becomes very diluted for each individual, and that's when things happen for the worse. So how do we prevent ourselves from even getting to the hospital? Again, practice all the anti-contagion measures. Make sure that, when you talk, it can spread, and when you breathe, it can spread. So keep a distance. No need to be in close proximity until such time that slowly this will get mitigated. When we all do it together, I think it can happen. By mingling with all the festivals and the elections going on and all kinds of things happening out there, including the Kumbh Mela, from what I hear, is part of the problem. And I think we need to be using common sense, number one. Secondly, yes, build your immunity. Don't drink alcohol because that suppresses the immunity. Don't smoke, suppresses the immunity. Eat lots of fruits and vegetables, and that will bring on the immunity, and put all the Indian spices, which brings on the immunity. That's why our tradition goes for 10,000 years with all the spices that we add to our food, that there is a basis for all of that. And then drink plenty of hot food. I mean, there are all kinds of myths out there, inhaling to drinking hot, to doing all of that. Again, all of that may have a value, but we don't know, in the research studies that we haven't really done any of that. But what pills is out there that we can prevent? It doesn't look like hydroxychloroquine or chloroquine made any large impact in the global picture, but there are some suggestions that it may be helpful as well. We actually published a paper just recently for COVID and the pathophysiology, and put an algorithm of different kinds of medications to use the minute somebody is positive. The minute somebody is negative, how do you prevent them from becoming positive? Again, this is anti-contagion. Can we stabilize the endothelium is the question, so that even if you get COVID, it's it's not going to cause that problem with cytokine storm because the endothelium is protected. How do we do that is a big question mark. A new drug may come this year, but we're not sure. The answer is that we don't know. If only we knew, then we would not be in this space quite yet. We wanted to study an agent in the US, it is called Endothelium, excuse me, which has multiple different components come together with glucuronidase and hyaluronidase. Having some throat issues here. But it's not, the FDA is still not approving even for us to do the clinical trial because they want us to get it cleared with what is called an IND. So we're waiting for that. But I don't know what the answer is. I think do what you think is right. And we started a new registry. You can go online now and put your data in so we can track for hundreds of thousands of patients. It's called Coromec, C-O-R-O-M-E-C, coromec.org. It's an international registry trial. And maybe we'll know with what people are doing and what is protecting people from getting complications of the disease. Maybe we will all get it, but then if we can protect from complications and worsening, and then maybe build our own immunity, hopefully we will all be safe. But I think we have to do whatever we think is right from all the anti-contagion CDC public health measures, guidelines for now. No cure that we know of with preventing the onset of COVID yet. I'm hoping something will show up. Vaccination obviously is very important. Believe in the science, have faith, because you drink the water. How do you know that they're not putting poison in the water? Don't question the vaccine. They're all doing amazing people at the back end. Dr. Suresh, Jacob know that people who are at the back end doing the work with PhD and doing the vaccine, they all doing it, all the good intentions. Maybe there are other people who may want to think about the money component of it, and there is big money and they may be in cahoots and all of that. You can always get schizophrenic about all of that concept. But remember, if you don't get the vaccine, you get the disease, then you're on a slippery slope. You get the vaccine, one of the three things will happen. Either it won't work because it's placebo, no big deal. It will work because it is true and genuine and it will show effect long-term, so great. And number three, it might do harm. So through one out of the three is doing harm, and the harm so far in the short term is some side effects. We don't know the long term. We don't think it is going to be affecting our DNA or anything significantly. And remember, we had polio vaccine. We had every vaccine on earth. Dr. Suresh will tell you about pediatric, and all the vaccines that we have actually utilized have been successful. Have faith, have belief in the vaccine, get it so that we all can be protected together. Thank you.
Thank you, Dr. Chris. I think on that note, we should end, and I would request Dr. Jacob Jesurin to conclude the session. Jacob?
Yes, sir. Yes, sir. So, Dr. Chris, sir, it was a great pleasure listening to you. It was super amazing, and we would love to have you for more sessions. We would definitely invite you. You've been so magnanimous to accept and come over and give this amazing lecture for us. And sir, as a medical practitioner, not as a cardiologist, I'm not a cardiologist. So I have a question too. We hear of post AstraZeneca vaccine thrombotic complications. We have seen quite a few, and I've seen a few physicians advising aspirin 75 milligram after the AstraZeneca vaccine. It's marketed as Covishield here. What's your take on that, sir? And we'll close with that. Sorry, Suresh, sir, for that one extra question.
No, absolutely. I would say from a diet perspective, I'm also holistic, as you know. There may not be any research to back up my statement, but in terms of the diet, we traditionally from southern part of India, we have rasam every night. So the rasam contains something very amazing. It is the tamarind, which is the chemical is called tartaric acid. Now, tartaric acid is very powerful 10 times more powerful than acetic acid in dissolving calcium and the plaque inside the and stabilizing the inner lining, the endothelium. So amla or tamarind and the turmeric and black pepper and ginger, if you didn't know, the Plavix, or we call it clopidogrel. Clopidogrel actually was actually brought from ginger. So ginger is the origin of the blood thinner, Plavix. So ginger is a very powerful blood thinner, and the baby aspirin, 81 milligrams is what we have. I think you have 75 in India. And I think it is a good idea to take a little bit of that and keep the blood flowing on a continuum so that there is no clotting factors that happens. I heard AstraZeneca clearly had some issues, but I think statistically it may not be relevant quite yet. But I think time will tell and pan out. But be cautious about that clotting and make sure that don't smoke, don't have a risk factor for clotting, don't take the contraceptive pills or estrogen or progesterone, which trigger the clotting. So anything that triggers increased clotting tendency, where the people who take the vaccine may actually have a propensity to clot. So baby aspirin is a good idea, and avoid and continuously keep flowing the blood flow. So there is no even opportunity for the blood to clog up, because you're allowing it continuously keep drinking fluids that are good for you without too much carbohydrate in it, which will continuously keep the blood flowing like a river, and don't allow it to stagnate like a pond, then it'll accumulate clot.
Thank you so much, sir. That was a beautiful and pictographic explanation. And thank you so much. I really love the way, I really enjoyed the way how you mix science and philosophy, as Suresh sir said, along with hardened facts from the past. You take a leaf from history and nature, and so beautifully blended with our own system of medicine. So thank you so much, sir. It's been an amazing evening with you. I'm sure our participants will also reflect the same. And thank you for coming over, sir. Suresh, sir, it's been a great honor and pleasure listening to you too, sir, to your amazing worldview and perspective of preventive cardiology. And it's been an amazing listening to you too, sir. And I would like to also thank all our participants in the webinar. It's been great to have you all on board. I think many of you have come for the first time from different colleges from across the country. We've got quite a few from Tamil Nadu and Maharashtra and other places. So this is a noble initiative, absolutely non-profit initiative, where we are looking at reaching out to all the 500 medical colleges in the country, and we are looking at reaching out to all the medical students. So if 500 students are there in a college, so in 500 colleges, we can reach 2.5 lakh students minimum. So there are so many students in so many of these colleges who don't have good teachers, right? So that is a fact. So this is the passion and the drive behind this initiative. It has begun small, and we are looking at really succeeding, and with amazing speakers like Dr. Chris sir today, and brilliant moderators like Suresh sir, I think, and of course with support from the medical student and junior doctor fraternity like all of you, I'm sure that this program which we have started as a earnest and sincere seed will grow into a beautiful tree. So thank you so much. Any final comments from the speaker? So I think you are.
Dr. Suresh, Dr. Jacob, fantastic summary. Dr. Suresh, thank you for being here. Amazing moderator, and I'm hoping to meet you in person and gain some tremendous knowledge. And your comments were so spot on, and I'm so honored and blessed to have been here. A big thank you.
Such a great pleasure.
Thank you. Thank you, everybody. Have an amazing evening. Stay safe. Be masked up. Maintain social distancing. Let us avoid and prevent COVID, because it's burning. Let's help each other. Let's build up this broken nation. Thank you so much.
Thank you. Bye-bye.
Thank you so much.